Welcome, Dr. Venkatesh Munikrishnan. Of course, you are colorectal and robotic surgeon at Apollo Hospitals in Chennai, one of the highest volume robotic surgeons in the world, and of course, a real privilege to be your friend and colleague. I thought that we would have a little discussion around the benefits of minimally invasive surgery, in particular robotics, and the collaboration that we have had over the years, and how you see collaboratives like that going forward.
Thanks for the chat. Looking forward to having this discussion and sharing our views, because we've done lots and lots of work together, and it came from a chance meeting. You want to talk about it?
No, I think it's been hugely exciting, the journey that we've been on, and we were one of the very first collaboratives really that began to span at least 3 continents, potentially 4 if you say that the UK and Europe are not the same, but a chance meeting that we had, and then a collaboration that included Professor Stephen Wexner, Professor Antonio Lacey, and the 2 of us that led to some real great things for education. But also, I think we've been able to share our experiences towards patient care. And all of us, I'm sure, have learned from each other to optimize our practice. Is that what you found as well, Venki?
Absolutely, Manish, because when we met in 2016, September, if I remember right, by that time, that December, you were doing your first meeting. I know the whole world has gone gaga with online meetings and Zoom calls and webinars. You were front runner. You did this in 2017. You got a group of specialists together in a room, and we webcasted to about 30,000 people in 2017. Fast forward 2020, people are just replicating what you did 3 years ago. So what?
No. And I mean, I think that worked very well, as you said, for educational purposes. But I think one of the important things that we saw with all of this is how we can then, where appropriate, use our expertise to discuss patient cases across big geographical boundaries.
Absolutely, because at that point, we had just started our colorectal institute, a few years old. We're just starting robotics. And the next thing which we needed was to put in processes and patient care protocols. And one of the important things which we needed to do was multidisciplinary team meetings, which the UK and the US had lots of experience, particularly starting off in the UK, and the US followed that. And we now in India and the wider Asian region really need to take the MDT forward. And so that's when, after you finished your meeting, and then we had our first meeting in Chennai, that's when we said, okay, let's start this patient collaborative, protocol-driven approach, learn from what you guys have already achieved in the UK and the US with Prof. Exner and yourself. And we set up the MDT. And today, 3-4 years down the line, we have completed 130 meetings or something like that, and patients have been discussed. A collaborative MDT approach has been taken particularly for rectal cancer. That's become the standard. And so our patients are extremely grateful. And so much so, a few weeks ago, Dr. Pratap Reddy, our chairman, came online for our online virtual MDT, and he was so appreciative of the initiative taken from where this all stemmed out from our meeting, and it's gone on to influence patient lives.
No, I think that's huge testimony, I think, to also your organization and the setup that you have in Apollo Hospitals. Of course, is one of the most prestigious healthcare institutions in India. But if we move on to actual practice and practice changes, I think we've seen, particularly in the last few years, a real drive towards minimally invasive surgery. And many of the patients both you and I treat are patients that are having operations for colorectal cancer. I still see many patients that have come to me and have been offered open surgery. And yes, of course, there is a place for open surgery in a selected group of patients which are technically challenging, or there's a problem with the tumor that necessitates that kind of approach. But my feeling is that too many patients are still being offered open surgery as opposed to a minimally invasive approach. And I'm not sure that's the right thing, particularly for clinical outcomes and also for the patient's perspective, particularly.
I agree, because I think looking at how surgery has evolved, 20 years ago when I first came to the UK, that's when lap open surgery was standardized. TME came in for, if you're taking rectal cancer, for instance, you've done a lot of work in that area and are an expert in that. With your work with Gina Brown is stuff of legend, because you really got into it. Why it is so important is that, for example, rectal cancer care is standardized. You do an MDT, you make the right decisions, and then the TME approach, popularized by Bill Heald, is whether however you do it, open, lap, robotic, it still has to give the same results. So how many of your trials you're going to do, it's not going to change the final outcome. But what will change, or what will be the difference between open, lap, or robotic, will be the short-term outcomes, where patients have quicker recovery, less blood loss, less length of stay, quickly going back to their normal lives, better nerve preservation, because you're seeing things better. And I understand when people are told that some surgeons feel that they have to feel and and see where the tumor is, but inoperable, we're talking about rectal cancer here, inoperable rectal cancer surgery, I think most of that data or the operability or all that has already been assessed in your MDT. All the data is available in your MRI, CT, everything is there. So I don't think you will, 99% of the time, if you've done it properly, going to see any surprises. As long as you're going to do a good TME, you're going to achieve the same result, whether it's open, lap, or robotic. But the most important thing for the patient is that the cancer cure, which we've achieved because the technique is standardized, but the short-term results, which are, as we discussed, are much better with minimally invasive surgery, and also functional results like nerve preservation, sexual function, and continence. There is evidence to show that it's better with minimally invasive surgery. So I think we have to push for that, or at least give the options to the patient.
Yeah, no, absolutely. And I think one of the things here that we should really get across is that unless there is a specific reason to do so, patients should really be offered a minimally invasive approach. My feeling is that when patients are not offered such approaches, it really comes down to two things. One of those is lack of resources, potentially, but I also think a lack of training and expertise. And if that's the case, then I think that should be made clear that this is the reason. It shouldn't be sold on the premise that, oh, actually, it's a better operation. Because actually, I think we've now got enough evidence to suggest that minimally invasive surgery is a better option for patients that are having colorectal cancer operations. And I hope that is the message that patients are being told when they go and see their surgeons, because ultimately it is our duty to be offering our patients the most optimal treatment plans, and not necessarily the ones that suit ourselves, because actually it may be the case that you need to refer a patient on to somebody else if that particular patient warrants a different type of surgery.
Absolutely.
Okay, so if I move on to the final part of this short podcast that I wanted to discuss with you, your vast expertise in robotic surgery, and this is of course something that we're doing now at the London Clinic. We're very excited to have this new XI machine in the Institute of Robotic Surgery at the London Clinic. But share your thoughts as one of the highest volume robotic surgeons in the world about how you think this can benefit patients and why we should be offering our patients that type of approach where appropriate.
Yeah, great question. And I think robotics, I was very skeptical when I started out, because I was saying, one, there's multiple, I thought it takes more time to set up and, maybe more cost. And there's several issues to address. But as I keep telling everyone, the person who convinced me is Dr. Reddy. I think he saw it because he has been in patient care for so long and, has set up private healthcare, particularly in India, as we know it. And he foresaw that robotics as technology really changes everything for the surgeon and for the patient. And when we started our program out, yes, it took a bit longer because it was new technology, we got to get used to it. But once the program was rolling, what we saw was the operative time came down, the setup time came down, the short-term results were great. And also, once you become a high volume surgeon and a high volume center, the cost is comparable to laparoscopy, and in some cases will be cheaper to it because you have become so independent of external factors because your robot will support you to do all that. And then this becomes even more important, particularly in the context of this pandemic, because we are looking at more and more less sort of contactless or reducing the number of people in the theater environment. So the robot will help you to replace or at least remove the extra people who are there to come and assist you or, do some suction. Everything can be done with the help of the robot. So what our experience has been that as your experience goes up, the time comes down, the cost comes down, and the short-term results are showing because patients are getting better. Our length of stay technically is about 4.5 days, which is brilliant. Our patients come from out of town, so we have a different patient model. So they stay for 6 days. They're ready for discharge for 4.5 days for rectal cancer surgery, but technically they leave on 6 because they're from out of town. But you will see that these short-term benefits all add up. 1 for the hospital, 2 for the patient, 3 as a surgeon. You could do 2 procedures, 3 procedures at a time because you would not feel tired because you have this great tool at your disposal, which really, really changes the game compared to what we do in laparoscopy when you're standing and with straight sticks. I think it's a game changer. And it's going to, with the advances like ICG, which is inbuilt like Firefly, which makes the operation more safer, and then technologies which are going to be built in like feedback and is really going to change the world of surgery for us.
I think you're absolutely right when you say that the benefits to the patient are tantamount here, and that may be more so perhaps for the precision that you're able to obtain with these difficult, challenging operations. Yes, they can be done laparoscopically. Yes, of course, they can be done open. But I think the key here is to limit and minimize the surgical stress to the patient. And doing it in this fashion with these advanced instruments, I think is a huge benefit for patient recovery.
And particularly rectal cancer, because you have such stable platform, you can do this dissection, get into these very low tumors because patients don't want to lose their sphincters. And I think getting very low on the pelvic floor, doing a reconstructive surgery is so much more straightforward, easier with the robot compared to laparoscopic surgery. The conversion rates to an open operation with the robot is 4%, laparoscopy is 16%. So there are several short-term benefits, which particularly in rectal cancer surgery, I think in a few years' time, robotics will be the standard. And I'm already seeing it. Our data are now about 250, 260 cases. So we're going to hopefully publish it very soon, which will be a template for lots of surgeons who want to pick it up. But we're seeing the results, and I'm sure it will reflect when it's adopted widely.
Well, with that, I'd like to thank you very much for spending the time with us today, Dr. Munikrishnan. I think benefiting from your experience. Of course, I've spent some time operating with you in Chennai. It's a fantastic city, fantastic place to work, fantastic institution. And it sounds like we'll be looking forward to the publication of your very impressive clinical outcomes in due course. So thank you very much, Dr. Munikrishnan.
Thanks, Manish. See you soon.
See you soon.